When you add it to patients who are already on glimepiride and metformin, it further improves their sugar control. So in both settings, as an add-on after metformin and as a third drug after metformin and sulfonylurea have stopped working or are working suboptimally. So why then can we use sitagliptin metformin combinations initially? Yes, you can. You can use sitagliptin metformin combinations very easily. Sitagliptin, as I told you, is a DPP4 inhibitor. Why? Sitagliptin works primarily on the beta cell, whereas metformin works primarily at the insulin resistance level. So you have, like you use sulfonylurea metformin combinations, you use glibenclamide metformin combination. Glibenclamide stimulates insulin secretion, metformin improves insulin resistance, right? So similarly, this will improve insulin secretion and metformin will improve. The advantage of this combination, however, is that both sitagliptin and metformin do not produce hypoglycemia. So when you use a combination of sitagliptin and metformin, the risk of hypoglycemia is not there. When you use drugs like you use Downil, Amryl, whatever, you find very commonly hypoglycemia. You start your patient on medicine today, 3 days later they will call you and say, lunch ke pehle ekdam chakkar aata hai, office mein baide pasina aane lag gaya, घबराहट होने लग गई, whatever. That is typical. But with sitagliptin metformin, you don't get low sugar reactions, almost zero. Almost zero. That's a huge advantage. They act in complementary pathophysiological manner. I think we leave this. So fixed dose combination of sitagliptin metformin can be considered in some patients as initial therapy for newly detected type 2 diabetes. They have good mechanism, complementary mechanism of action, combined action, 24-hour reduction, and basically no hypoglycemia and no weight gain. So when you're moving towards drugs more and more that don't cause hypoglycemia and don't cause weight gain. And I do feel for the first time now that actually sulfonylureas will go down in the pecking order. They will clearly go down in their overall importance in type 2 diabetes. The only factor limiting it is the cost right now, because sulfonylureas are so cheap that we would use them more. But over a period of years, as the costs balance out, I expect that that gliptins or DP4 inhibitors will replace sulfonylurea to a large extent as second line after metformin. So your paradigm would be in a few years from now, metformin is always first choice, we all know that, right? The second add-on would commonly be a gliptin rather than a sulfonylurea. Last few minutes, just to say, there are some unresolved issues regarding incretins. They are new drugs. We don't have long-term cardiac data on their safety. There is some fear about some episodes of pancreatitis which is still being investigated and not proven to be drug-related. And there are others which I will not go into. But the first two, I think we need to keep in mind that there is no evidence to suggest that they are not safe. But, you know, we need to keep in mind they are new drugs. You may find 10 years later that there was a difference in cardiac outcomes, or you may find greater risk of pancreatitis. But these are only suspicions right now. They are not at all proven, and there is no evidence that cardiac drugs will be in any way, cardiac effects will in any way be counterproductive in this case. And the last 2 or 3 minutes I will spend on straight away going to this, which is the American Association of Clinical Endocrinologists, which have taken a very practical view of how to manage diabetes. You don't have to read all of it. It's okay, I'll explain what I mean by this. This is just taken straight from the journal so that we can't change that. I mean, that is how it is published. We are looking at patients who come to us for the first time, and we are dividing them into 3 groups. A1C 6.5 to 7.5, which is pretty reasonably controlled, mild diabetes. Or we have A1C 7.6 to 9, which is the typical patient who comes to you, uncontrolled diabetic. Or you have HbA1Cs more than 9, which is a poorly controlled diabetic. How would we choose drugs in these patients in 2010? That is the question. What has 2009 taught us in this regard? Let's look at the typical patient who comes with A1. No, okay, let's start with this one first. Let's start with the A1C of 6.5 to 7.5. You could use anything as monotherapy. You could use metformin, you could use TZDs, you could use DPP4 inhibitors. I would limit myself to one line here. The first line of drug in almost all diabetics would be metformin. So we should not get confused about that. Metformin is the basis on which we build our therapy. But many patients don't tolerate metformin. They get GI upsets. In such cases, the use of gliptins is very reasonable. So if you look at this, you can use either metformin, Even glitazones, we are not going into that today, but you could use DPP-4 inhibitors also if patient is not tolerating metformin. If you want the patient to be on 2 drugs, the patient is not getting managed with metformin alone, then it will be very safe to add a DPP-4 inhibitor to metformin as a second drug. You could also, of course, add sulfonylurea, which you will still do in most cases because of cost effectiveness, etc. But the choices would really be here between DPP-4 and sulfonylurea as the main choice to add on, which is a change. We've always told metformin, then sulfonylurea, then anything else. But now you say even at second line, I can think of adding a new drug like a gliptin, sitagliptin, rather than always adding, glimepiride or glipizide. We leave that part. Let's say a patient comes with A1C of 7.6 to 9. Patient is uncontrolled diabetic. You would usually start with combination. That is well established. We've spoken about this so many times. When a patient comes with uncontrolled diabetes, not like mildly uncontrolled, but significantly uncontrolled diabetes, you straight away start with the combination. Here again, it's very reasonable to start either metformin will always be there. Either metformin and sulfonylurea or metformin and DPP-4. And I showed you the advantage of starting metformin DPP-4 inhibitor is it's oral, it's taken once or twice a day, it has no effects on weight gain, in fact maybe some weight loss, and it does not cause hypoglycemia. Whereas when you use metformin-sulfonylurea combination, the risk of hypoglycemia is very significant. So you have to balance out based on your patient what you choose, but you have a clear choice here. You could use either metformin-gliptin combination or you could use metformin-sulfonylurea combination. We won't go further into that. And supposing you have patients who come with really high HbA1cs, what would be your drug of choice? Usually patients who are 10, 11 HbA1c, sugars of 250, 300, and if they have symptoms of weight loss, etc., you would start insulin straight away. That of course is there. But there are a lot of patients who walk into your OPD with 300 sugars and no symptoms and nothing, and they say we are feeling perfectly fine. There you could consider using straight away a dual combination, that is a metformin plus DPP-4 or metformin plus sulfonylurea. Maybe even a third drug if required. Triple drug combinations can be used in these patients. So the idea of taking you through this is not to confuse you, but just to highlight changes that are taking place. The fact that choice of drug is not as simple as it used to be, that we have many, many options. And the key points that emerge, the take-home messages from this will be as follows. Number one, metformin remains drug of choice, first drug for almost all your diabetics unless it is not tolerated. Secondly, when you add an oral antidiabetic agent, you could add a sulfonylurea as you have been doing, which works very well, but where there is some risk of getting low blood sugar and in the long run some weight gain. Now you also have the option of adding a gliptin in place of sulfonylurea there, right to metformin at the second stage itself, where there is no risk of hypoglycemia and there is no weight gain, but the cost is higher, significantly higher. That is the second message. The third message is that if somebody is not controlled on 2 drugs, which is typically in our practice, metformin plus sulfonylurea, even there you could consider adding a gliptin to improve control. That is how I would put it. Just one line before I close, because everyone must be wondering why I have just brushed over glitazones. And we don't want to get into the glitazone controversy today, but just to say, pioglitazone can still be used in type 2 diabetics. It is a relatively safe drug. It has been shown to have many beneficial effects. Because of the weight gain and edema, it is not first, second line in clinical practice, but it is very much there. So there is no need to drop pioglitazone. Of course, rosiglitazone is more or less out for various reasons, including its effects on the heart. So I've tried to put in several things together and tried to give very simple messages, and I'll be happy for any discussion. Chairperson, sir.
Thank you, Dr. Mittal, for excellent presentation, and I'll request the audience to give you a big hand. I think this was the best way, because the way he has told when the HbA1c, what time, which group of the drugs you have to, but one thing to be remembered, the treatment of diabetes is individualized. And not a one protocol will be followed. It has to be the individualized, and individual patient needs an individualized therapy.